Usually when we talk about a medical diagnosis, there's this expectation of like mechanical precision.
Right, totally. You want it to be black and white.
Exactly. I mean, you break your arm, the x-ray reveals this jagged white line, and the doctor simply points to it. Broken or not broken, it's clean, it's visible, and the path forward is undeniable.
Yeah, but unfortunately, that's rarely the reality in neurology.
No, not at all. When you step into the world of pediatric neurology, specifically the treatment of infant seizures, that metaphorical x-ray machine is just, completely shattered.
Shattered into a million subjective pieces.
Right. You find yourself navigating these diagnostic, muddy waters that have been churning for, nearly 2 centuries now. So for you, the learner, joining us for this June 5, 2026 deep dive, this is a look into what happens when the very words we use to describe a medical condition actually become the biggest barrier to treating it.
It really is a fascinating and honestly somewhat terrifying look at medical history because, we crave perfect categorization, especially in medicine. Yeah. But when clinical labels become this rigid dogma, the downstream effects on real vulnerable patients are just profound.
They really are. And to really dissect the source material we have today, we're going to look at this through 2 distinct lenses.
Right. So I'll be approaching the data from the perspective of a medical researcher, analyzing the historical classifications, the shifting diagnostic criteria, and the raw electroencephalogram, or EEG, data.
And I am taking the perspective of the clinical practitioner because, my ultimate concern is the boots on the ground, patient care on the neurology ward, real-world hospital protocols, and the devastating reality of treatment delays. Okay, let's unpack this, because to understand why a modern doctor might inappropriately delay giving life-saving medication to an infant today, we really have to start with a desperate father 180 years ago.
Yeah, back in 1841.
Right, 1841. Dr. William West wrote this letter to the Lancet describing his own infant son, James, who was suffering from what he called peculiar convulsions.
And that letter, that is the genesis of our entire modern classification system for these conditions. Dr. West described these sudden bobbings of the head his son was experiencing.
Just sudden drops.
Yeah, exactly.
Yeah.
He was very clearly documenting a physical, observable event. In medical research terms, he was describing an ictal phenomenon,
right,
which refers to the actual lightning strike of the seizure itself, the physical spasm you can see happening in real time.
And we know tragically from historical records that James West never developmentally recovered. The seizures coincided with a permanent halt in his cognitive development.
Yeah, it's heartbreaking.
It is, but it took over a century for the medical community to even attempt to formally name what was happening. Skip ahead to 1952, researchers Gibbs and Gibbs coined the term infantile spasms.
Right, and they used it specifically to describe that physical seizure type. They even referred to them as miniature convulsions because they lasted only like a second or two.
Which makes sense.
It does. That should have been a clean categorization. Infantile spasms equals the physical seizure event occurring in infancy. But the medical literature almost immediately derailed.
Of course it did.
Yeah. For decades following the 1950s, major medical monographs, research papers, textbooks, they all began using the term infantile spasms and the broader term West syndrome, completely interchangeably.
Which is wild.
They treated the physical symptom and the overarching epilepsy syndrome as if they were the exact same thing.
And as a clinician, I cannot emphasize enough what a nightmare that is for standardized care. Like, imagine running a respiratory ward where half the staff thinks a chronic cough is the disease itself.
That's right.
And the other half thinks the cough is just one symptom of a broader disease, like pneumonia. If your textbooks use the symptom and the disease as synonyms, how do you write a hospital protocol?
You can't. It's impossible.
You literally can't. If a baby comes in with these sudden head drops, some doctors would write down infantile spasms and call it a day, while others would look for a broader syndrome.
And this confusion reached the highest levels of global medical governance. The International League Against Epilepsy, the ILAE, went back and forth on this for decades.
Oh, back and forth was dizzying.
In their 1970 guidelines, they classified infantile spasms strictly as a seizure type. But then by their 1985 classification system, they had totally backtracked and were using West syndrome synonymously with infantile spasms.
That makes no sense.
And then a 1992 ILA workshop actually proposed abandoning the term infantile spasms entirely. It was just an absolute taxonomic merry-go-round that severely polluted clinical research.
Because it fundamentally breaks the scientific method.
Right.
Like if one research hospital is running a drug trial for infantile spasms and defining it as any baby with a head drop, and another hospital is running a trial defining it as a complex multi-symptom syndrome, their clinical data cannot be combined.
No, it's comparing apples to oranges. If we connect this to the bigger picture, the ILA finally put their foot down in 2017. They published an instruction manual that definitively separated the two concepts.
Finally.
The ruling is now absolute. Infantile spasms is strictly a seizure type occurring in children under 2 years of age. West syndrome is the actual epilepsy syndrome, the broader condition that encompasses those physical seizures along with other neurological factors. We finally separated the cough from the pneumonia.
Which is a massive relief. But separating the physical symptom from the broader syndrome instantly forces us to confront the mechanism that connects them.
Right, the bridge.
Yeah. If a baby is having infantile spasms, how does a doctor officially diagnose them with the broader West syndrome? Historically, that bridge has been an EEG test looking for a very specific, highly chaotic brainwave pattern. And this brings us to the crux of the sources we are reviewing today, the hypsarrhythmia conundrum.
Oh, hypsarrhythmia. It is arguably one of the most problematic concepts in modern pediatric neurology. Let's look at the neurobiology for a second here.
Yeah.
When a doctor runs an EEG on an infant, they're measuring the electrical activity of the brain. We talked earlier about the ictal phase, right, the seizure itself. But doctors are also looking at the interictal phase.
The space between.
Exactly. This is the background electrical activity of the brain between the physical spasms.
Right. What is the brain doing when the baby appears perfectly still and resting?
Well, in 1952, when Gibbs and Gibbs were defining infantile spasms, they also defined a specific interictal EEG pattern they observed in these infants. They named it hypsarrhythmia. Visually on a chart, it is a pattern of continuous, random, extremely high voltage, slow waves mixed with scattered electrical spikes.
It basically looks like absolute electrical chaos.
Chaos, yeah.
And let's explain why that specific chaos is so dangerous to a baby. An infant's brain is in a critical window of development. It's trying to lay down billions of neural pathways, learning to smile, to reach, to babble.
All those milestones.
Right. And that requires organized electrical signaling. If the background brain activity is in a state of continuous high voltage chaos, it acts like a deafening static interference. The brain literally cannot lay down those developmental tracks.
It's just too loud, neurologically speaking.
Exactly. This state is known as an epileptic encephalopathy. The abnormal electrical activity itself is actively degrading the child's cognitive function, totally independent of the physical spasms.
And that mechanism is why treating this condition is a medical emergency. But here is the fatal flaw in the diagnostic process. Because hypsarrhythmia was associated with this developmental stalling in the 1950s, the medical community turned it into a strict prerequisite.
A gold standard.
Right. Seeing that specific visual pattern of chaos on the EEG became the absolute gold standard for diagnosing West syndrome and initiating heavy-duty treatments.
But I have to challenge this historical reliance based on the source text. I'm looking at the original 1952 report from Gibbs and Gibbs, and they explicitly call hypsarrhythmia the easiest to detect of the cerebral dysrhythmias of epilepsy.
Easiest to detect.
Yeah. If the founders of the term called it visually obvious, how did it evolve into this highly criticized exclusionary hurdle?
Well, because the initial 1952 cohort was essentially a localized echo chamber. They reported that all 237 of their patients had the pattern, but as soon as other clinics started looking for it in 1959, the numbers just fell apart.
They couldn't replicate it.
Not at all. Modern data is incredibly clear. Roughly 40% of children who present with unquestionable infantile spasms do not have this classic hypsarrhythmia pattern on their EEG.
Wait, 40%? That is a staggering failure rate for a diagnostic gold standard.
Oh, it gets worse when you look at how doctors actually interpret the charts. Recent studies, specifically by researchers like Hussein and his colleagues, analyzed the inter-rater reliability of hypsarrhythmia.
Okay.
They took the exact same infant's EEG readout and handed it to multiple, highly trained pediatric neurologists. The agreement was abysmal. Neurologists looking at the exact same squiggles could not agree on whether the pattern met the threshold for hypsarrhythmia.
Because it's completely subjective. The definition is chaotic, high voltage, slow waves. Like, what exactly constitutes chaotic enough? What is the exact visual threshold for high voltage?
Exactly.
It is the medical equivalent of asking 3 art critics if a Jackson Pollock painting is messy enough to belong in a museum. You are literally relying on a gut feeling.
And the clinical fallout from that subjectivity is where your perspective really comes in.
The clinical fallout is terrifying. The standard treatments for these infants are intense. We are talking about ACTH, which is a powerful hormone injection, high-dose corticosteroids, or vigabatrin. These are drugs with massive side effect profiles.
They're not gentle.
No, they are hard on an infant's body. Consequently, a clinician wants absolute ironclad proof before they prescribe them. So an anxious parent brings in a 6-month-old with visible spasms. The doctor runs the EEG. But because the interpretation is subjective, the radiologist doesn't explicitly type the magic word hypsarrhythmia on the report.
So the treating clinician hesitates.
They hesitate, or they withhold the heavy-duty drugs entirely and try something milder that simply doesn't work. Time is brain development. Every single day that the chaotic background static is allowed to continue, permanent neural connections are lost. We have built a system where life-altering therapy is gated behind a visual test that 40% of infants fail, and that doctors can't even agree on when they do see it.
It's tragic. And here's where it gets really interesting.
Oh, right. Tell them about the outcomes.
The source material notes that the presence or absence of classic hypsarrhythmia on a pre-treatment EEG does not even predict how the child will respond to the medication.
Wow.
It does not predict their risk of subsequent long-term seizures, and it does not predict their ultimate developmental outcome.
So it is a completely functionally useless metric for guiding patient care. We have been clinging to a historical hangover just because it was printed in a textbook in 1952. If the visual test is failing the patients, we clearly need an objective mathematical solution.
Which is exactly what the research community developed. Recognizing that subjective visual interpretations were actively harming trial enrollment and patient care, they introduced a new diagnostic framework in 2021. The BASED score.
Yes, the base score. This feels like the pivotal turning point in our sources.
It really is.
This is like moving from art criticism to a standardized rubric. We're no longer asking doctors to subjectively interpret if a painting is an impressionist masterpiece. We are giving them a checklist of exact brushstrokes so they can make an objective call and start treatment immediately.
Spot on. BASED stands for the burden of amplitudes and epileptiform discharges.
A mouthful, but important.
Very. The goal was to completely eradicate the subjective hunt for hypsarrhythmia. Instead of looking for a vague overall pattern of chaos, the BASED score is a rigorous mathematical 0 to 5 grading scale applied to the EEG data.
Okay, let's break down the mechanics of how this scale actually quantifies the chaos in an infant's brain.
The scale is driven by hard numbers. A score of 0 is a normal EEG. To move up the scale, the algorithm looks at extremely specific variables. First, it measures the percentage of 1-second bins that contain spikes.
Okay.
Second, it counts the spike foci, meaning it looks at the exact number of distinct geographical areas in the brain that are firing off abnormal electrical signals. Finally, it measures the peak-to-peak amplitude, which is the literal electrical voltage height of those errant waves.
So instead of a doctor squinting at a screen and saying, well, that looks really chaotic, we are using a diagnostic computer to measure the exact height of the electrical static and counting the precise number of misfires happening per second across different regions of the brain. It's objective.
Completely objective. And the grading scale correlates directly to the severity of the brain's dysfunction. A BASED score of 4 mathematically indicates a probable epileptic encephalopathy. A score of 5 indicates a definite epileptic encephalopathy.
Got it.
And remember that encephalopathy is the continuous static interference that stalls development.
The clinical application of this is just brilliant. If an infant scores a 4 or a 5, you have undeniable objective proof that the brain's electrical environment is hostile to development. You no longer need the word hypsarrhythmia. You have a number.
Exactly.
You can justify immediately initiating those heavy-hitting treatments like ACTH or vigabatrin because the math proves the danger is real.
And the validation data for this score is incredibly strong. When researchers applied the BASED score to children presenting with infantile spasms, 93% of them had a pre-treatment score of either 4 or 5.
93%. That is a massive leap in capture rate compared to the 60% we were seeing with the old visual hypsarrhythmia standard.
Huge leap. Furthermore, it solves the inter-rater reliability crisis. Because it relies on strict mathematical thresholds for voltage and spike frequency, two different doctors looking at the same EEG data will calculate the exact same based score.
No more debating the Jackson Pollock painting.
Right, and this has revolutionized clinical research. By replacing the subjective hypsarrhythmia requirement with the objective-based score, nearly all children suffering from infantile spasms can now be enrolled in treatment trials. We're finally capturing that missing 40% who were previously excluded from the research pipeline.
We have achieved incredible clarity here. We know that infantile spasms strictly refers to the physical seizure. We have acknowledged that visually hunting for hypsarrhythmia is a dangerous subjective relic. And we have established the base score as a reliable mathematical tool for proving epileptic encephalopathy.
We have.
Armed with these three facts, how do the sources suggest we rewrite the rules for diagnosing West syndrome on the hospital floor today?
Well, the modern clinical guidance completely restructures the diagnostic criteria to be as inclusive as possible. To diagnose West syndrome today, a clinician must confirm the presence of the seizure type, infantile spasms. That is the baseline requirement.
Right. The physical head drops, the bobbings, the outward symptom.
Once the physical symptom is confirmed, the criteria require one of two additional features. The first option is observing developmental abnormalities in the infant, coupled with any definitively epileptic EEG reading. If the infant is already missing milestones and the brainwaves are abnormal, that meets the threshold.
But we don't want to wait for an infant to start missing developmental milestones to treat them. We want to catch it early.
Exactly, which leads to the second option. If there are no developmental abnormalities yet, the clinician can diagnose West syndrome by proving the presence of an epileptic encephalopathy. And as we just discussed, that can be cleanly and objectively proven by an EEG reading that generates a high-based score.
And just to ensure diagnostic accuracy, the criteria note that we must exclude alternative age-dependent epilepsy syndromes like Lennox-Gastaut syndrome.
Right.
Lennox-Gastaut generally presents in slightly older children with a different array of seizure types, so distinguishing the two ensures the child is on the correct specific medication pathway.
Definitely. But, the most profound element of this new clinical guidance isn't just what it includes, but what it explicitly omits. The word hypsarrhythmia is entirely gone from the diagnostic requirement.
Good riddance, honestly.
I agree. Another crucial omission is the requirement for the physical spasms to occur in clusters. Previous guidelines, particularly the 2004 West Delphi Consensus, demanded that a baby experience the spasms back-to-back in a clustered series to qualify for the diagnosis.
I remember that.
Yeah, but the new guidance states that single, isolated spasms are enough.
And from a clinical perspective, that is a lifesaver because spasms can be incredibly subtle. A slight shoulder shrug, a brief widening of the eyes. Unless you have an infant hooked up to a 24/7 video monitoring unit, an exhausted parent is very likely to miss a cluster.
Oh, absolutely.
Telling a doctor they have to wait to witness a documented cluster before they can prescribe treatment is functionally asking them to sit on their hands while a baby's brain development stalls. Time is brain. The ultimate takeaway from these new guidelines is that failing to meet rigid, outdated criteria must never be used as an excuse to withhold therapy.
This raises an important question. How does the global medical community rapidly re-educate itself?
That's the million-dollar question.
We are talking about abandoning 70 years of ingrained clinical habit. Entire generations of pediatric neurologists were trained to look for hypsarrhythmia on an EEG and to wait for cluster spasms. Shifting the culture of an entire medical specialty from a subjective visual hunt to an objective mathematical framework like the base score is going to require a monumental, concerted effort in ongoing medical education.
It is a massive ship to turn. But as the sources make painfully clear, turning that ship is the only way to stop failing our most vulnerable patients. Let's recap this journey for you, the learner. We started in 1841 with a father's letter describing his son's peculiar convulsions, a letter that inadvertently launched a century-long taxonomic trap where the medical field conflated a physical symptom with a complex syndrome.
We then dissected the hypsarrhythmia conundrum, exposing the devastating neurobiological and clinical realities of using a highly subjective, frequently missing EEG pattern as a gatekeeper for vital therapies.
And finally, we explored the elegant math of the 2021 based score, a 0 to 5 scale that replaces visual guesswork with objective measurement, allowing us to finally build an inclusive modern framework for diagnosing and treating West syndrome without delay.
It really is a testament to the fact that scientific progress isn't just about discovering new drugs. Often it is about having the courage to recognize when our old diagnostic frameworks no longer serve the truth. and then building better ones.
So, what does this all mean for you? Whether your daily focus is medical taxonomy, historical data analysis, or simply designing systems of classification within your own profession, the lesson here is stark. Rigid adherence to historical terminology, clinging to a diagnostic label just because it's been in a textbook since 1952, can have disastrous real-world consequences. We must be willing to update our rubrics when the data proves they are causing harm, which leaves us with a final thought to mull over. If a 180-year-old diagnosis for infants was held back for decades simply because brilliant doctors were conditioned to look for subjective, chaotic squiggles on a chart, what other established medical gold standards currently sitting unquestioned in our modern textbooks are actually preventing patients from getting the care they need today?
Now that is a deep dive for another day.
Indeed it is. Thanks for diving in with us. Keep learning, and we'll catch you next time.